Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. Good evening. On behalf of the Saudi Neurology Interest Club, I am very pleased to be welcoming our very shining speaker, Dr. Abdulaziz Aldbas, Senior Neurology Resident at King Abdulaziz Medical City. Dr. Abdulaziz will be sharing with us a session today titled Approach to Nystagmus. Dr. Abdulaziz, the mic is yours.
Assalamu alaikum. Thank you for this invitation and this introduction. As introduced, my name is Abdulaziz Aldbas. I'm a neurology resident in King Abdulaziz Medical City, and I've been asked to give a talk about approach to nystagmus, and hopefully, inshallah, you will enjoy and learn something valuable today. Do you see my screen? Is it clear? Okay, good. So inshallah today we'll go through nystagmus. It is a very common term that you will hear, especially for those who rotated in clinical neurology in the hospital, either in the internship or in the clinical part of the blocks in the university. And our part is to make it very simple. When you hear it, you know what they are talking about, you know how to describe it, and you know how to differentiate between other similar type of movements. So we'll be talking about a general introduction about nystagmus, and we'll pass by to other eye movements, because if we only talk about nystagmus, it can be easily confused with other eye movements. So our job here is to make you able, by the end of this lecture, to see an abnormal movement, to decide whether it is nystagmus, and to give us a reason why it is a nystagmus, or if it's other type of eye movements, and again, why is it not nystagmus. So we'll talk briefly about neuroanatomy. So what are the structures that is responsible for these eye movements, and where is the dysfunction exact that can produce such similar movements? And we're gonna learn, and the third objective is the most important one, is how to describe an eye movement. So we're gonna go through it today to see a patient in front of you. You see at the primary gaze you have a movement, or when you are examining the extraocular eye movement, you see a movement. We're going to learn today how to describe an eye movement and to objectively put it in a statements. So you can decide what is it, or if you're going to call someone else, a consultant, or to tell him about this movement, you will be able to objectively and in a clear language describe it for him. And then we're going to talk about the clinical significance. What does that mean in our clinical practice? And finally, we're going to go about the localization and etiologies, and subsequently the investigations needed. We'll talk briefly only about the management of the nystagmus. So this is a quote I liked when I was reading the extraocular movement chapter in Bradley, that I don't know of any kind of work better fitted for correcting loose habits of observation or careless thinking than study of ocular motor nerves. It's very accurate. It is extremely complicated. Ask any neurology resident, or even a general neurologist, not a neuro-ophthalmologist, a general neurologist. Everyone knows that it's a little bit a weak point for anyone, a scotoma, let's say, for any neurologist, the neuro-ophtha in general. It is complicated, it needs revision. Even if you read once or twice, you might be easily confused. So it is one of the complicated topics that need your full attention to understand it, and maybe a lot of repetition to really grasp the concepts. So let's go to first discuss about the eye movements in general. So what do we mean by eye movements? Normally, your eyes are supposed to be stand still, looking at an object, right? At a target. So an eye movement meaning that there is oscillations. Oscillation meaning a dancing-like movement of the eyes. So that can happen and can mean a lot. Means a lot of things. So we have nystagmus, we have saccades, we have opsoclonus, ocular flutters, and other things as well. So since our objective is nystagmus, let's talk about it, and let's put some rules. So in the future slides, when someone tell me nystagmus, you have to really tell me why. So when you say nystagmus, there has to be at least one rule present, which is a presence of slow wave of the eye movement. So when you have an eye movement that going left and right, back and forth, nystagmus has to have a slow phase in its movement. So slow phase, then fast phase, or slow and slow phase. So this is nystagmus. If there is no slow wave in the movement, this is not nystagmus. This is something else. Okay, so let's agree on that first, and let's talk about the other things. So if we don't have a slow phase in the eye movement, we are talking about other things. We have saccadic intrusions, which can include opsoclonus, ocular flutter, also square wave jerks. We're going to talk about them in the next few slides. And this is just an introduction. Okay. We're going to talk also about the general approach, how to differentiate. But this is only an introduction that you have to tell me there is slow or fast. Is it slow, slow? Is it slow, fast? Or if there is no slow wave, then the second question is if there is a saccadic eye movement or not, and then we'll be able to describe our movements. So we're going to talk more about in the next few slides about how can we describe each one, but this is only introduction. So as I mentioned, nystagmus must include a slow phase or a slow phase. And we call this pendulum nystagmus, otherwise it's something else. So opsoclonus, ocular flutter, and saccadic introjens. So if anyone can maybe answer. So if I tell you what's the definition of opsoclonus, for example, how can we define it, if anyone knows? Anyone in the mic or in the chat? So if no one answered, so opsoclonus basically, it's a spontaneous eye movement, fast oscillations. So there is no slow wave. It's a fast oscillation that goes back and forth without slow phase. So we call this opsoclonus. There is no saccadic component of the movement. So it does not stop at visual target, then move to another. No, it's spontaneous. Spontaneous movement, no slow wave. It's only fast. We're going to see some videos, but this is the description of opsoclonus. Ocular flutter, it is the same thing. Yes, it is. It can be caused by paraneoplastic. We're going to talk about this later on, but now let's focus on description only. So I want you to be able to really describe something, and you have to know what you see. So ocular flutter, it is similar to opsoclonus. The only difference is ocular flutter, it's the movement that is happening only in the horizontal plane. So if we have a fast movement without saccadic component, any continuous movement with no stoppage at any visual target and no slow wave, like they are dancing, in the only horizontal plane, this is ocular flutter. If it's only going vertical, horizontal, and everywhere, we call it opsoclonus. Otherwise, the description is similar. Okay? When the saccadic introjens are different, they are eye movements and you have now your eyes are focused on one object, and then it will move to another object and stops there. So it is like moving from visual target to another. So there is a stop point, and then another stop point that we call the saccadic introjens. We're going to see some videos. It is really difficult to understand these things without videos. So I'm just going to describe the concepts, try to understand them, and then the videos will be, inshallah, more clear. So does anyone know the subjectively, the patient will be, is he going to be complaining of anything? If it's only nystagmus? And if yes, what's the complaint? What do we call it? So there is a term for the nystagmus from the patient perspective. Yeah, the vision will be disturbed, but dizzy is a general term. It's not, it is very unspecific. And vertigo is the same thing. So vertigo, dizziness, this can happen, but it's not specific. It's very general, vague symptom. There is a certain term we used for the nystagmus from the patient perspective, which is the oscillopsia. Okay, you can Google it. Oscillopsia, it's a nystagmus from the patient perspective. He can see his eyes. Yes, exactly, oscillopsia. So the eye are moving and he see the image is disturbed. It's continuously moving, dancing movement. So he can see it from his perspective. So this is oscillopsia. So these are one of the complaints that the patient can come up with if it's only nystagmus. Right. So we have described a couple of eye movements we're going to be talking about. Now we're going to talk briefly about the anatomy. The pictures are a little bit depressing, I know. It is complicated anatomy, but we are only concerned about or interested in a couple of structures. So we're going to go about the general statements, then we'll be more specific as we go on. When we talk about nystagmus, we are usually talking about something infratentorial in the brainstem and cerebellum. In the brainstem, we have the gaze centers that are responsible for moving the eyes, and we have the connections between them that can help the eye to stop at certain visual target to keep it that way. Okay, cerebellum has an integral role in balancing balancing these eye movements and keeps them more coordinated. As we know, this is the general function of the cerebellum. So in general, you will see this repetition with each side. Brainstem lesions, cerebellum, and cerebellum lesions are usually the culprit when you talk about nystagmus. Okay, most of the time they are the culprit. Midbrain, medulla, cerebellum, these are the culprit. So I'm going to talk about one concept. I hope you can keep up with me. So one of the main mechanisms of nystagmus is something called burst excitatory and inhibitory neurons. So imagine that you are looking at the laptop now. You are keeping your eyes fixed at one target, and let's say you move to look to the right to another target. Okay. Well, there are function of certain integrators, we call it neural integrators in the brainstem, that can help inhibit the muscles that will make your eyes goes back to this visual target, which is not the desired. Your desire is to make your visual target to the right, keeps it to the right. You want to look there, keep your eyes there. So this is the desired movement. So normally in our ocular system, there are systems that will inhibit the antagonist muscle that will make the eye go back. Okay. And there are excitatory muscle that will make the eye overcome any anatomical structure such as muscles or tendons to go to the desired visual target. So when these connections are disturbed, nystagmus might result. So there will be slow drift of one eye and then a corrective phase. So these are one of the mechanisms. So the exact structures that is implicated in nystagmus, we have vertical ones and horizontal ones. When we talk about the vertical, we have the neural integrators, as I mentioned, for the vertical and torsional, which is the interstitial nucleus of Cajal, okay, INC. So this one located in the midbrain, and mainly they are in the vertical plane. Okay, so any nystagmus in the vertical plane, usually this nucleus or its connection are implicated. So if it's impaired, there will be some sort of nystagmus, as we mentioned, with the same mechanism I just explained. So we have another nucleus for the horizontal, which is located in the medulla, which is a nucleus prepositus hypoglossi, NPH. And we have another one not mentioned here, which is the medial vestibular nucleus. Both of these nuclei are responsible for the horizontal eye movement coordination. Okay, both of them located in the lower brainstem, most of them. As I mentioned, additional important structure is the brainstem, such as the folliculus and other parts of the brainstem that is responsible for coordinating these eye movements. Not only that, you can imagine, just by understanding the basic anatomy, that there is an extensive connections between these nuclei, and any lesion in these connections might give you such abnormality. So I will not go into details because it will be boring for you, the detailed anatomy, but this is the general concept. And this is the usual localization and the culprit and when we talk about nystagmus. And basically that's it. For the vestibular part, I put in the right the vestibular system. You can see in the right. I put it there because it is also one of the important things in nystagmus is the vestibular. So any vestibular dysfunction can give you nystagmus, decrease, especially with the head movement. We're going to talk about it in the acute vestibular syndrome in the next few slides. We'll mention it slightly, but this is a separate lecture. It's very difficult to cover it. I have a separate lecture for approach to vertigo, where we can discuss detailed anatomy of the vestibular system, how exactly the vestibular system gives you nystagmus, how to differentiate between different types. This is is a little bit not the core of this lecture. طيب, so if you tell me from these slides, what is the most important one? This is the most important slide. Take a picture and know how to do or how to answer these questions. This is the most important thing. If you do this, you will impress everyone in front of you at clinical practice, whether either you are an intern, a resident, whatever. So this is what we do when we encounter an eye movement. So we in our minds, we answer these questions and eventually we come up with an impression. So regardless of the patient complaint, we're not talking about now a clinical picture. A patient came with diplopia, with weakness. This is different. History and examination is really different. Now we are concerned about how to describe an eye movement, how to delineate it, how to classify it. So you need to answer all of these questions in order to have a proper description, and you can give subsequently a proper classification. So is the movement present at the primary gaze? Does it have a slow phase? As we mentioned, this is a very important question because you'll know it is a nystagmus or not. So slow phase is very important. Is there a fast phase or it's a pendular nystagmus? There is a vertical or horizontal or both? Is it conjugate, disconjugate, meaning that does it present in both eyes or only in one eye? Some childhood problems, when there is a decompensation, we call it latent nystagmus. It will present only with one eye. Not very dangerous, it's only decompensation from stress or other things. So conjugate, disconjugate, meaning both eyes or one eye. This is also an important question. Torsional component. It's also an important part. We are going to see it in one of the common syndromes, such as the BBV, positional benign vertigo, peripheral vertigo. We can see torsional component with Duxhol bike. Is it gaze evoked, multi-directional, going in all direction, or bidirectional, or unidirectional? This is all very important. One very important question. What does it mean to say multi-directional, unidirectional? What does this mean? Does anyone know? So does this mean that nystagmus is present when I move my finger to the left, it will be there, or the right, or both, or there is a specific definition for the direction of the nystagmus?
I think if it's multi-direction, it means when I move my finger, it will be present in multiple planes. And the same bidirection is like the same, but in only two planes, and unidirectional is only seen in one plane. So, for example, just horizontal.
Okay, so this is maybe you are using logic, but it's not actually the case in case of nystagmus. So it is the direction of the fast phase. So when you talk to a neurologist or neuro-ophthalmologist or an ophthalmologist over the phone, for example, you are telling him it is bidirectional. He will assume that you are saying that it is a nystagmus that has fast phase to the right and to the left. So when I move my finger to the right and the end gaze, he will have a fast phase, nystagmus that is beating to the right, same side of my finger. When I move to the left, he will have again a nystagmus beating to the opposite direction. So I have now bidirectional, meaning I have two direction for the fast phase. So the way we are describing nystagmus, it's by the fast phase only. Okay, so the direction of the fast phase is the direction of the nystagmus. Right meaning beating to the right, left meaning beating to the left. This is bidirectional. Okay, unidirectional meaning it's a nystagmus. It might be present. Let's say it's left unidirectional. Let's say it's left unidirectional nystagmus. When I move to the left, it will be beating to the left, right? But it might be present when I go to the right. However, the fast phase will be to the left, will still be to the left. So it is unidirectional. Regardless, it's present when I move there or there, it doesn't matter. What matters is it's consistent unidirectional fast phase. Okay, that's how we describe it. Gaze evoked, meaning whenever I go with the eyes, any gaze, it will be there beating to the same side, meaning the fast phase will beat to the direction wherever I go. Okay, when I gaze evoked nystagmus, similar to multi-directional. Okay. Yeah, we'll talk about this, about the physiological. We'll talk about it. So usually it's seconds. It will not persist, fatigable. Few beats and it will stop. So physiological can present at the end gaze, and this is benign nystagmus. It's normal, but the difference is it is fatigable. Only few beats, and it will stop. And if you go a little bit medially to the nose, it will stop immediately. It shouldn't be there. Only at the end gaze. So this is a very important concept. that the direction is the fast phase. The direction of the fast phase is the direction of nystagmus. This is the common language whenever you talk to someone who's an ophthalmologist or neuroophthalmologist. Okay, and another question, does it become prominent with elimination of fixation, meaning there is an nystagmus, and when I close one of the eyes, it deepens, it decreases. So this is one of the things that is telling you it's more of a peripheral, not central. This is an acute vestibular syndrome, different topic today, but yani, one of the things you need to do whenever you're describing an eye movement or an nystagmus. So is there an intersaccadic interval? So if there is an intersaccadic interval, this is not a nystagmus. We are talking about other eye movements, as we mentioned. So if we have a fast phase and we don't have slow phase, we have only fast phase. If there is no intersaccadic interval, we already agreed that this is opsoclonus, ocular flutter, right? The difference between them is the multi-directional or only the horizontal plane. If there is an intersaccadic interval, this is different. We're going to see some videos, but this is different. We have one of the most common eye movement with intersaccadic interval is square wave jerks. Okay, it is very small with very small eye movement with microsaccadic interval. So this is different, but it's a very important question to understand what you are dealing with. Okay. And after you do all of this, you have done your homework, you will be able to objectively describe an eye movement in front of you. Okay, so this is very good for practice. Keep it with you. Remember these questions because this is how you describe an eye movement. Okay, so for those who are visual learners, this is from Continuum article. They put diagrams for the different eye movements. So if you can see from the top here, this is the general approach. So is there a slow phase or not? This is the first question. Okay, if it's yes, well, this is nystagmus, right? So, okay, so now the next question, is it only slow phases? If it's yes, only slow phase, no fast phase, this is pendular nystagmus. And these are all an example of conditions where you might have a pendular nystagmus. Okay? If there is a fast and slow phase, we call it jerk nystagmus, meaning that there is a slow phase and corrective rapid fast phase. And these are a lot of nystagmus, a lot of types. We're going to go through most of them, I think most of them, through the videos. But these are very common conditions you might see where you have a jerk nystagmus. Okay, so jerk nystagmus meaning there is a jerk, right? Slow and then jerk, fast phase. Okay, so if there is no slow phase to begin with, so only fast. So here we are going through the saccadic abnormalities. Okay, so saccadic abnormalities, there are two types. The first type that does not have intersaccadic interval. As I already, this is the third time I'm repeating this for you to understand because it's not a very easy or simple concept. But the movement, the saccadic movement that does not have intersaccadic interval is a opsoclonus and ocular flutter. Okay, and it's like dancing, continuous dancing movement, no intersaccadic interval. So if there is an intersaccadic interval, we're going to have a couple of other movements. Square wave jerks, the most common. We have other thing called macrosaccadic and the microsaccadic. Okay. So this is generally how you approach. In this diagram, they have summarized what we just discussed. Okay, they summarized everything. Okay, and in this diagram down there, they are just I don't like this, by the way. I read about it. I read the nystagmus. I reviewed a couple of things. I put the presentation. When I found this, for me, I did not like it. It's not my way of learning, but I put it there because some people might like it, and this is how they learn, visual learners. So they put you the pendular nystagmus. It's like a wave that is only slow. Here there is slow and fast wave, meaning that there is jerk nystagmus. Some of them are decreasing or increasing in velocity. And here they are putting you the square wave jerks. You see here the interval. Here the line, there is a stop. There is a movement, then a stop at the visual target, then it will continue. We call this intersaccadic intrusion. Okay. For those who have done with us clinical neurology, I am sure one of you are they have attended with us. When you examine an elderly man, for example, because this you will find this common, and you are telling this man to look at your finger and follow it with his eyes, you will notice that it's not very smooth. He is like there's interruptions. He's following your finger, but most of the elderly patients are not very smooth with the eye movements. That means there is a saccadic introjections, meaning there is a stop and then continue, stop and then continue. They are focusing on multiple visual targets until they reach your finger. So this is basically, I'm trying to make you very comfortable with it. This is the intersaccadic interval. We call it saccadic introjections, okay? Because normally it's supposed to be smooth. And this is basically how you describe it, and this is the approach, okay? We have mentioned a lot of things about nystagmus. So why is it important? Why do we need to know all of this, to describe all of this? Because it's very important in many clinical scenarios. One of the most common, or in the most common scenario where you're gonna need a good knowledge about nystagmus, it's the acute vestibular syndrome. It is very common. Especially ER physicians, they deal with this a lot, and they call us a lot for that because of the concern for strokes. So, vestibular neuritis, PPVs, these conditions that are very common, and they are commonly present in the ER with very bad presentations. They have severe vertigo, nausea, vomiting, but the cause is benign. So one of the most important ways to diagnose the patient at the bedside is the understanding the nystagmus patterns and to differentiate whether this is peripheral, vestibular neuritis, for example, or central, could be stroke. Uh, this is a little bit outside of the scope of this lecture, and you have different lecture for vertigo, but we're going to talk a little bit about it now. So the second thing that is very useful is the localization value. Okay, so when you see nystagmus in a patient who came with headache, for example, and there is very concerning nystagmus in his exam, you will be concerned. You will think could be he might have a lesion or tumor or something in his brainstem. You might admit him and diagnose him appropriately. So it's has a very good localization value. And again, one of the clinical utilizations of nystagmus is seizures. Okay, we call ictal nystagmus. Okay, we can see it frequently, especially in the ICU where the patient is comatose. We can see some repetitive jerk eye movements. We will think immediately of seizures, and it can be very helpful to notice these clinical signs. And finally, as I mentioned, oscillopsia. This is very irritating symptoms to many patients, and there are available treatments that can be tried with these patients. So it's important to identify them. Like now, let's come to the history and examination. So I'll leave the mic to you now. What do you think what are the most important things to cover in history and examination of such patients? Okay, onset and medications, good. Trauma history can be. Yes, definitely other neurological deficits. You want to see there is another neurological deficit, stroke, you mean weakness and neurological deficits, of course. Inner ear problems, of course, but this is from the presentation. You mean vertigo. If the patient came with acute vestibular syndrome like intense vertigo and nausea, vomiting, it's one of the differential diagnoses to have vestibular neuritis, history of ear infection before. But this is clinical diagnosis. The ear infection is only supportive. Okay. History, of course, if it's obsoclonus or in a young male, for example, or even an elderly, history of cancer and paraneoplastic processes are important, of course. So headaches, I will add headaches. It's very simple. If patient has headaches and new nystagmus that is concerning for central process, this is very important. Okay. Okay. I will just open the chat because I think I missed a lot of. Okay. Just 1 second. Yes, so history of seizures, difficulty walking, double vision, worsen with hip movement. Exactly. So worsen with hip movement is important for vestibular source of nystagmus. Okay. And we mentioned already neurological deficits. Okay. طيب. So yeah, as you mentioned, so we're gonna usually in the history we're gonna screen about everything. So the history of the patient, any comorbidities. For example, if the patient has MS or not, one of the common presentation of the patient who's known multiple sclerosis, they might present with new onset nystagmus, not necessarily a new lesion, but from the previous lesion might act up and they might present with nystagmus and they are irritated by the nystagmus. We call it pendular nystagmus or acquired pendular nystagmus. Other history of strokes, as I mentioned, focal neurological deficits, headaches, seizures, cancer, a picture of vestibular syndromes, medications such as especially anti-seizure medications. They are known to cause nystagmus, so this is very important as well. طيب, this is the bonus question. I will be impressed by anyone who can really give us a good answer. So, during my talk, in this slide, I mentioned a lot of times if there is a central features of nystagmus. So let's say this is a nystagmus. We know it's a nystagmus. So how can I say this is a central or it's clearly peripheral? Could be due to vestibular neuritis, other causes, but this is not a central. So what are the differentiations? Okay. So onset direction. So what is the direction usually? So direction, this is only a statement. So what does it mean? What will happen to the direction of nystagmus in central or peripheral? Yeah, so exactly. So peripheral usually unidirectional. Okay. So peripheral is unidirectional. That's one characteristic feature. Sudden, it's not that helpful to be honest. And most of them will be sudden. Even the acute vestibular syndrome due to vestibular neuritis will be more or less sudden. So the sudden is not that important. It's important to understand the features. So peripheral, unidirectional. Okay, good. Central, not suppressible by eye fixation. Yes, it will not deepen with eye fixation. The central, correct. What else? So vertical. This
Peripheral.
is so vertical. It's central or peripheral. You mentioned vertical. Budur. You mentioned vertical. What do you mean by vertical? Is it central or peripheral? So central, yeah, vertical is very concerning for central. Okay. Peripheral can be suppressed by the visual fixation. The central has no auditory symptoms. Actually, it is true many of the times, but not necessarily because one of the stroke syndrome can cause acute hearing loss. It's ICA. ICA territory can cause acute hearing loss. So it's not a differentiation. You will depend mainly on the your examination, hint exam. And neurological deficit, of course, it will support your impression. So mainly unidirectional. Anyone heard of Alexander's law? Alexander's law. So we're gonna see it in the videos, but this is one of the laws that follow peripheral, meaning that you have unidirectional nystagmus, and this nystagmus will increase when you move the eyes to the fast phase. So when you move to the direction of the nystagmus, it will increase. When you go to the opposite side, it will decrease. So this is Alexander's law. It's very typical for peripheral syndrome, okay, such as vestibular neuritis. Okay, so that's one of the features we mentioned. Let's go now for the localization. We talked about many things already. So vestibular neuritis, one of the common for acute vestibular syndrome. We have also strokes in the brainstem and cerebellum or its connection can give you a similar picture. Any brainstem lesion, demyelinating infection, inflammatory paraneoplastic infections, anything in the brainstem can give you this. So we are talking about nystagmus as a clinical sign. Okay, this is how we think about it. The other things from history and exam, the history we talked about, the exam we talked about, the nystagmus only additional value or additional clinical value, specifically localization value. Okay. And of course, when we talk about what are the investigation you will do for this patient? Let's say you have a patient with nystagmus. What are the additional investigation? It depends on your impression. So vestibular assessment if you think this is peripheral, brain MRI if you think this is central, stroke management if this is stroke, and so on and so forth. Okay, and it doesn't go out of this. Usually, you will be circling in these investigations, and more investigation depending with the initial investigations you will do more afterwards. Okay, so we talked a little bit about this. We have some there is a repetition, sorry. So this tags to do vision loss, only one, not two. So we have benign forms of nystagmus. The physiological endpoint nystagmus, one of the most common ones. You see it frequently in young healthy patients. It means that when you move the eyes to the end point, to the extreme right, you will see few beats, but it shouldn't persist, only few beats, and it will stop. It is fatigable. And usually, if you move the eye not to the extreme, it shouldn't be there. Okay, so only end case. So this is the physiological endpoint nystagmus, not concerning, it is normal. We have latent nystagmus. This is usually in patients who have an issue while they are during their childhood, amblyopia or strabismus, for example, and it happened by it's a disconjugate nystagmus. So you close one eye and you move this eye with a problem, and you'll find nystagmus, but only when you close one of their eyes, because there is compensation somehow. So we call this latent nystagmus. And we have the nystagmus due to vision loss. We're going to talk about it in one of the videos, inshallah. But if there is an impaired vision in one eye, the afferent and the input from the afferent system is low, and sometimes it will result in inappropriate function of the burst inhibitory and excitatory neurons, the neurointegrators, because the input is low, so it might result in nystagmus, particularly pendular ones. Okay, so that can be from vision loss. So you might see it in patients with optic neuropathy, previous attacks in multiple sclerosis. You might see such movements. Okay, and the vestibular nystagmus we talked about already. It is severe presentation. The patient might be vomiting, nausea, vertigo, dizzy. It is dramatic presentation, but it's benign because the etiology is not severe. It is not malignant. It will resolve in hours to days. Okay, and it's not dangerous. So that's we call benign forms. So anyone has a question? Did I make nystagmus now more clear for you? Should you go for the videos now to describe them? Any question before we go to the videos? Okay. So inshallah it will be more clear because this is really a visual training. Nystagmus really need a lot of visual training. So inshallah it will be easier with the videos. طيب. I am not sure if it's clear. Inshallah it is clear. So let's describe an eye movement. I want to describe it and then tell me what you see, okay? Let's open it. Bismillah. Those who seen it in my channel don't answer because I have used it in my channel, Telegram channel. Okay, I'll play it again. Is it clear? Maybe this is better. Anyone? Yeah, so maybe all of you know it. Okay, so let's describe it from the video. So we see an oscillatory eye movement. We agreed on this. So do you see a slow phase or it's all fast? So if you can see, it's only fast oscillations going back and forth. Okay, spontaneous, right? So this is not an nystagmus because it's fast oscillations. Okay, there's no slow phase. One of the main rules we mentioned already, it's a presence of slow phase. So there is no slow phase. It's less likely to be nystagmus. The second thing is, do you see an intrasaccadic interval during the eye movement? So let's see now. So you have an eye movement. Any intrasaccadic interval, you don't see it because it is spontaneous. Okay, going back and forth. Okay, so it is not a movement with a slow phase, so not nystagmus. It is fast oscillations, no intersaccadic interval. So this is an ocular flutter, okay? So we call this an ocular flutter because there's no slow phase, no intersaccadic intrusion, and only the horizontal plane, okay? If it's in the horizontal and the vertical, we will call obsoclonus, okay? Let's see this movement. This is not in the channel, so this is a real test for you. So I'll play it again. Yes, excellent. So it is saccadic movement. Okay. So it is not nystagmus. Let's leave the direction. Don't talk about direction unless you define the eye movement first. So is it nystagmus or not? You remember the approach. The first question is it there is slow wave or not? And if there is intersaccadic interval. So this at first you have to delineate the question. So you can see here it's not slow. It's a little bit fast, but it will go from visual target to another. You can see here. So she is going from visual target to another. See, it's moving to the right and then stops there, then to the left and then stops there. So it is moving from the one target to another. See. So this is some form of saccadic intrusions because it is basically a movement from visual target to another. Okay, saccadic intrusions, and it is spontaneous. Sometimes eye movement, but at many times it's spontaneous. So look at it again and again. Okay, so you will be convinced. See, so she is looking straight, then her eyes move to the right and stops there. So change in the visual target. So saccade. This is called saccade. So definition of saccade is movement from one visual target to another. Okay, this is a saccade. It's called saccade. So you can see here it is moving from visual target to another. So this is saccade and it stops there. So we call this saccadic intrusion. Okay, and it is small, right? And spontaneous. Many times it's spontaneous. So we call this square wave jerks. Okay.
Mhm.
Okay. So I put the first two examples, and it's something not nystagmus, just to trick you, to make you understand what I'm saying. I hope it's clear. So why this is not nystagmus? Just I told you because of the presence of saccades, intersaccadic intrusions. Okay, and there is no clear slow wave. It's only saccades. Okay, so we call this square wave jerks. It can happen in any elderly patient and sometimes insignificant clinically. You can find it anywhere. But sometimes it is relevant. It can be present in neurodegenerative diseases such as PSP. Okay, so let's see this movement now. You can ask any question during any of the videos, that's fine, even if it's old video. سبحان الله. Okay. So, is it clear? So I repeat it again. Look at it يعني, as many times as you can. It is horizontal bidirectional. It is endpoint, but the endpoint usually for the physiological, but this is horizontal bidirectional nystagmus because you can see there is fast phase to the right and to the left. Okay, so look at it again. Let's repeat the video. Okay, so here, let's see when he looks to the left, there is beating nystagmus, slow, then beating to the left. Okay, so this is left now. Then he looks straight, and then the examiner moves his finger to the right, and the nystagmus start to appear slowly, and then more prominent, and to the other side. So the fast now to the other side. So we have two direction, and the horizontal plane is bidirectional, horizontal bidirectional nystagmus. Okay. Yes, if the fast phase is present, so the direction is the direction of the fast phase. The direction of the nystagmus is the direction of the fast phase. Okay, so that's how we describe it. And since there is fast phase to the right and to the left with each gaze, this is bidirectional. Okay, so it is bidirectional, and as you already explained. So what is the localization? Does anyone know? Where can we localize this? So it's not peripheral. This is very concerning for central. Okay, so bidirectional nystagmus is not peripheral. Peripheral is unidirectional. So bidirectional is concerning for central process. So brainstem correct, but it's very general. So brainstem exactly where. So as we mentioned, the connections of the structures responsible for the horizontal gaze, medial vestibular nuclei, and the presbyopia hypoglossi nuclei. These are the two responsible for the horizontal eye movements and can be implicated in case of horizontal nystagmus. And also the cerebellum, the volliculus specifically can be involved in such cases, especially if there is horizontal and vertical at once. Okay, so let's see the next. So this is a clear, inshallah. Okay. So describe before you localize, describe. So what is this? So correct, it is unidirectional nystagmus to the left side. Okay. And it's not saccade. Why did you say saccade? So you can see here, uh, when he moves to the right, it will deepen. It will go away. Let's see. At the primary gaze, it is present. It is beating to the left. You can see. This is not saccades. This is a dancing movement, an eye movement that beats to the left. there is a slow phase and then fast phase. Look closely. Okay, look closely. There is a slow phase drifting here and then fast to the left, drifting slowly, then fast jerk to the left. So it's not saccade. Okay. It is present at the primary gaze, so the patient looking straight, and it is there beating to his left side. Okay. When the examiner move to the right, make him move to the right, it stops. So no movement. When he moved to the left, the direction of the fast phase now became more prominent, even with the torsional component. Okay, even with the torsional component. So what do we call this? So what do we call this law? I explained the law where you have an eye movement that's become much worse at the direction of the fast phase. Yes, Alexander's law. Okay, Alexander's law. So this nystagmus follows the Alexander's law because there is fast phase at the primary gaze, as you can see at the primary gaze to the left. It will fade away when he moves to the right, and then it will become much more prominent when he looks to the left with some torsional component, which is very common for the vestibular or the peripheral causes to have a torsional component with the horizontal component. Okay, so say again, see the torsional component now. Look closely. So there is a torsional, not only beating, only there is torsional. Okay, with the horizontal there is torsional. Okay, so this is unidirectional. So unidirectional, as we mentioned, follows Alexander's law. More prominent when the patient looks to the same side. The fast phase disappears when the patient looks to the opposite direction. So localized, this is peripheral, can be localized to the vestibular nerve, okay, vestibulocochlear nerve, in case of vestibular neuritis or labyrinthitis. Okay. Yep. Now let's look at this one. I think this is very obvious and one of the most, because the video is very clear actually. So what do you see? Where is the slow? Where is the fast? Okay, it moves up and down, but there is characteristic. Is it the same speed? Is there a slow phase? Is there a fast phase? Let's see again. See?
وانا رايحة عند تحضير في الزوم.
Okay. Oh, there is a fast phase. It is down beating. Look at the movement to the downward. It is fast. Okay, and there is a slow drift to upwards. If you look closely, there is slow drift upward. Then, so now it will become very clear now with the gaze. See, slow drift upward, then fast downward. See now, it became very clear with the gaze when he moves to the right. Now it is very clear. So there is fast downward and then slow drift upward. Okay. So let's see when he moves it to the other side. See, it is now clear. It's fast, going like beating downward, beating downward, and with upward slow drift. See, it is drifting, then it will beat downward. Okay, it will become more prominent with the end gaze, with the right or left. All of you are quiet. I'm not sure if I'm not doing very good job explaining, or any you didn't understand what you see. And I hope it's clear. We are looking for fast and slow phase. So again, here you can see here there is a little bit slow drift upward, then down. It will be fast. Okay, there is two phases here, not only one phase, and it will become more clear when he moves to the end case. Let's see. See now. I'll just fast forward, fast forward, fast forward. See now. See. So it's impossible to have the same movement. It's clear. So it is beating downward and then slow drift upwards. Okay. So it is down beating. So down beating is nystagmus, right? Okay. So this is called down beating nystagmus. Okay. It is present at the primary gaze. It become more prominent when he moved to the side. This is very characteristics and has very characteristic localization. So downbeat nystagmus. Do you know where to localize it? What is the localization? We call it downbeating, not necessarily direction. It is downbeating. That's the terminology, any or shared terminology. So it is when you move to the right, it means something. It is characteristic for downbeat nystagmus, and it has specific localization. So anyone knows the localization? Downbeat nystagmus. So usually it has multiple localization. One of it is the cerebellum, that the nodulus, the cerebellum, and the medulla. So the lower medulla, we call it craniocervical segment. The lower medulla, craniocervical segment this is characteristic for it, especially with chiari malformation. Patients can present like this. Okay, so it is downbeat nystagmus. So we are reaching the end now. I think a couple of videos left. Let's see this one. Can you describe it? Yes, so it is upbeat. So this is upbeat nystagmus. You get it now. Okay. So you can see طبعا it is normal when you understand the concept that you will make a lot of mistakes initially because your eyes are not trained. Okay, one of the things that in the one of the activities we did with a neurophthalmologist, and the rooms was filled with senior ophthalmology resident and senior neurology resident, and we were fooled by many things. For example, an ocular flutter, we called pendular nystagmus. It was flutter, and the opposite, because the eyes of the neuro-ophthalmologist more trained than us to see the eye movement and the base of the eye movement. So it is normal to not to get it at first, but the most important thing is to train your eyes. Okay, as long as you have the concepts. So this is very clear. You can see upbeats with slow downward drift with upbeat nystagmus. So the fast jerk phase to the up, and then with slow downward drift. Okay. So this is upbeat nystagmus. The localization again can be the medulla, can be part of the midbrain, can be seen in Wernicke encephalopathy, okay, when it's affect the brainstem. So it has multiple localizations. Okay. Okay, this is upbeat nystagmus. Now let's see this one. I think we have two more videos to go. there will be a prize for whoever gets this one. It's not very easy, but try to get it. Correct. It is more prominent in one eye, in the left. It is present in the right, but more prominent in the left. Correct. So what is it? Let's describe it first. Let's describe the movement first. So I'll just play it once. Okay. It is disconjugate, yes, but this is description. This is not classification. Disconjugate. It's more than asymmetrical, more than the left. But what is it exactly? It is correct. It's an nystagmus for Dr. Fatima. It is correct. It is an nystagmus. But what is it? What kind of an nystagmus? So it's not bidirectional. This is pendular nystagmus. We call it pendular nystagmus. So you can see there is no fast phase. It is slow oscillations going back and forth, more in the left eye than the right, asymmetrical, but slow oscillations going back and forth. Okay, so we call this pendular nystagmus, as we agreed before in our approach and our classification. Since there is, see, it's very clear now in the beginning. It's very clear. See how slow it is. See how slow. It is very slow, going back and forth. Okay, so slow phase going back and forth. This meets our criteria for pendular nystagmus. It is more the left than the right. Okay, but it is pendular. So this patient has multiple sclerosis and has severe vision loss in the left. Okay, one of the things that multiple sclerosis can present with is acquired pendular nystagmus, sometimes due to the vision loss due to optic neuropathy, as we mentioned in the first few slides. So this we call it pendular nystagmus. Okay, and the localization basically, most of the references mentioned there is no specific localization. Sometimes the cerebellum, volvulus, I think the cerebellum specific word is volvulus, but no specific localization. Many references they mentioned due to the high lesion load in the brainstem, especially in multiple sclerosis, they might have this moment. And some patients, because of the severe optic neuropathy and severe vision loss, this might exacerbate this nystagmus. Okay. Okay, I think this is the last one. I tried to bring as many videos as I can because this is the way you're gonna grasp the concept. So this is very excellent, very interesting case. Don't think the video quality is not that much, but try to guess it. Okay. So right beating. What else? Anyone? I'll repeat it again. Look closely to the both directions. Sorry. I'm not sure if you saw the answer or not. Inshallah not. Just 1 second. Let me double check. Okay. Okay. So again, look closely at the both directions. This is a little bit advanced question, but it's a very interesting movement. Correct. It is horizontal nystagmus. Let's agree on that. Excellent. This is horizontal nystagmus. Okay. And it is bidirectional. Correct. But there is a distinctive part of this video. So let's see it together. So you can see in the right, when the patient looks to the right, it is large amplitude. You see, there is large amplitude movement. Let's see from the beginning again. See? See now, it's large amplitude. Okay? Very large. When the patient looks to the left, now the amplitude is less, but it's very fast. Both beating to the same side. It's bidirectional. But here, the amplitude is large. Okay? It's more clear in the right because the amplitude is large. Let's see here. Let's see here. Okay? So here the amplitude is large. When he moved to the left, so there is high frequency, very fast, but not as large as in the right, but more faster. Faster, but lower amplitude on left. Okay? Does anyone know what do we call this? It's not pendular. There is a fast phase to the right. So there is a fast phase. When the patient looks to the right, there is a fast phase. When the patient looks to the left, there is a fast phase, although not very clear at the left because it's a small amplitude. But there is fast phase in both directions. So it is bidirectional horizontal. However, again, the last time before we see the answer, it's large amplitude here when he looks to the right. When he moves to the left, it becomes lower in amplitude, but very faster, faster in term of frequency. Okay. So we call this a bronze nystagmus. Okay, a bronze nystagmus basically a bidirectional horizontal nystagmus where you have one side high amplitude, low frequency, the other side is high frequency, low amplitude nystagmus. Okay, fast phase, and it's localized to the CB angle. Mostly CB angle hemorrhages, CB angle tumors. You might see this. Okay. Last slide, this is just a summary about what I talked about. I can share the tables with you. Here they are summarizing the localization, the causes, and the treatments. So the common symptomatic treatment is baclofen, gabapentin, and memantine, some with variable success between each type. And these are the references I used. I used Bradley and Continuum for most of the videos and the content. Thank you very much for listening. I think I took the whole hour and I hope you understood something today. I tried my best to make it as simple as I can, but inshallah you understood something. If you have any questions, you can always reach me through my email, my Telegram, or my Twitter. And for those who didn't join the Telegram channel, you can always join. This is the barcode. You can join it where I share from now and then any content about neurology. Thank you very much. If you have any questions, I'll be happy to answer them.
Thank you, Dr. Abdulaziz, for this insightful lecture. It was very entertaining. Now, for our attendees, please kindly fill out the survey that has been sent in the chat and give us your feedback so we can issue the certificates for your attendance. يعطيكم العافية جميعا.
يلا يعطيكم العافية. توفيق جميعا.